Morning, everyone. Welcome. I thank you for joining us for today's Knockout Opiate Abuse Day Learning Series webinar, Building Resiliency Among Healthcare and Addiction Professionals. And I know this is a really important and significant topic. I know a lot of you have asked for this topic to be addressed. I'm glad that we can all take a moment today to pause and learn some self-care and some tips on how we can improve all of the work that we do. Some housekeeping notes. Today's webinar is designated for 1 AMA PRA Category 1 credit, 1 ANCC contact hour, 1 ACPE contact hour, 1 AAPA Category 1 CME credit, and 1 ADA CERP continuing education credit by the American Academy of CME Inc. And for any pharmacists claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has also been approved by NJOEMS for 1 EMT elective CEU. So welcome our EMTs as well. The Partnership for a Drug-Free New Jersey is approved by the Board of Certification, Inc. to provide continuing education to athletic trainers. And this program is eligible for 1 maximum Category A hour of CEU. PA Planner, Dean Barone, discloses that he serves on the Speakers Bureau of Ethicon and Johnson & Johnson. But all other planners, faculty, and reviewers have no relevant financial relationships to disclose, and all relevant financial relationships have been mitigated. Today's webinar is jointly provided by the Partnership for a Drug-Free New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares and the Office of Alternative and Community Response, the New Jersey Office of the Attorney General, and the Opioid Education Foundation of America. And I thank them for their ongoing partnership, support, and collaboration on today's learning series, webinar, and activity, and throughout this year-long learning series, which I can't believe it's November. We're coming to the end of. So I'm so pleased to welcome our expert faculty who are here with us today. We have Dr. Erin Breedenberg, who is a hospital medicine physician and a board-certified addiction medicine provider at the University of Colorado Hospital. Welcome. And Dr. Shivendu Sen, who is the Vice Chair of Research and Faculty at Jersey Shore University Medical Center of Hackensack Meridian Health. And welcome to you as well, Dr. Sen. And so, Dr. Breedenberg, I will turn the presentation over to you.
Great. Thanks so much for having me here. I'm excited to be here. So I'll be talking a little bit about a study that I was the principal investigator for, looking at factors that contribute to burnout and resiliency among hospital-based addiction medicine providers. Next slide. I have nothing to disclose. Next slide. So a little bit of background. So again, I'm a hospital medicine provider. I spend about half of my clinical time working on general hospital medicine services and the other half working on our inpatient addiction medicine consult service. The rationale for this study was really that on our addiction medicine consult service, we're seeing very sick patients. So for those of you who aren't familiar with this model, essentially anybody who gets admitted to the hospital for whatever reason, if they're using substances, they want to talk to somebody about their substance use, we can consult, we can help with management of intoxication and withdrawal, primarily opioid intoxication or withdrawal. We initiate buprenorphine, we initiate methadone, we help connect people with treatment at discharge. We can help provide resources for intensive outpatient therapy when people discharge, inpatient. Sometimes we can discharge people directly to inpatient rehabilitation facilities. So we're really there to, fill this gap for people who are experiencing hospitalization and to intervene in a population that may otherwise not be connected with resources. So our service has been around since 2019, late 2019, and the rationale for this study came out everyone who works on our service, or at least all the physicians, are experienced hospitalists. And when the service started, some of our providers said, this is really, really hard. People are really sick. They have severe substance use disorders. We don't have any kind of longitudinal follow-up. So when we see people more than once, it tends to be because they're not doing well and they've gotten hospitalized multiple times. And so we hypothesized that hospital-based addiction medicine providers might be at a special risk for burnout because of these factors. And so that was sort of the rationale for this study. Now, we talked only to inpatient providers, but I think you'll find that most of our findings are very relevant sort of across the board. Right, next slide. So the aim of our study was to look at factors associated with burnout, compassion fatigue, engagement, and resiliency among hospital-based addiction medicine providers. Next slide. This was a qualitative study. We conducted approximately 1 hour Zoom interviews with people across the country. Our participants were addiction medicine physicians, advanced practice providers, and social workers from these services across the US. Just a brief word about sort of why we elected to focus on those groups. The structure of these services varies pretty widely across the country. Some people we talked to, they just have one physician who's working alone on these services. Our service, when it started off, was a physician and a social worker working together. There are often peers who work on the services. There are often navigators or care coordinators. But most commonly, it seemed that there was a medical provider, physician, APP, and then a social worker. And so we chose to focus on just those provider types. So just a caveat that we are missing some very important provider types in the voices that came out in our study. We emailed consult service directors directly, and then we did snowball sampling, and then we coded our data and conducted a thematic analysis. Next slide. So we use this model for burnout and resiliency. Dr. Shanafelt is an expert in burnout, physician burnout specifically. And the idea is that there are these 7 domains, and within each one of these domains, if things are better or worse, that can contribute to engagement or conversely burnout. And so these domains include workload and job demands, control and flexibility, work-life integration, social support and community at work, organizational culture and values, efficiency and resources, and meaning in work. And so when we were developing our interview guide, we used this model. We asked questions in each one of these domains. We used this model to sort of be the lens that we looked at our analysis through as well. And we actually showed this picture to participants at the end, and we said, does this feel like it's an appropriate model when we're talking about burnout and resiliency? And is there anything that you want to add? And pretty much across the board, people felt like this really captured sort of those elements that contribute to either burnout or resiliency in their work. Next slide. So we interviewed 26 people, just noting the time frame. COVID was still very much present during this, so late 2020 to the beginning of 2021. That's not something I'll talk about directly, but it did come out in many of the interviews. We interviewed people at 12 different institutions across the country, and we had representation from all areas of the country. And then our interview pool was pretty physician heavy, as you can see. Next slide. Again, just to give a little bit of context, of our participants, most were internal medicine trained, and then we had a few who were family medicine and psychiatry trained. Most of our participants, actually, this was not their only work. So like myself, they were hospital medicine physicians who also worked part of their time on these services, or some people were family medicine physicians who did some outpatient addiction medicine. Some people did exclusively outpatient and inpatient addiction medicine. But most people had sort of another job or another role in addition to doing this work. And then just to mention, these consult services are very much exclusive to academic facilities. So most of our participants worked with learners. We on our service work with addiction medicine fellows, we work with resident physicians, we work with medical students, PA and NP students and fellows. And so that was a pretty common finding, is most people worked with learners. So again, just to give a little bit of context when thinking about these results. All right, next slide. So we elicited 3 themes with 6 sub-themes. Next slide. The first one I think will come as no surprise to anyone. And again, I think this is a very universal finding, but really when people talked about the things contributing to burnout, they talked about systemic barriers more than sort of the addiction work itself. Next slide. So the first thing that people talked about were barriers at an institutional level. And this first finding is the one that maybe is the most unique to the inpatient setting, but I think, again, really can apply across settings. So people perceive this misalignment between hospital-based medicine and patient care needs. So hospital medicine is very much, you admit the patient, you discharge the patient the second they're ready to go, whether or not that's really big picture the best thing for the patient. And so a lot of our providers felt that this was really detrimental for patient care, and that particularly, an extra day or two in the hospital to help connect people with resources for their substance use disorder would really go a long way towards helping them with sort of the big picture of their healthcare. And that hospital-based medicine was really not set up to do this well. There's so much pressure to discharge patients very quickly. And so that was something that came out very frequently. Another thing that came out was hospital policies that limited the use of methadone and buprenorphine. So limiting, just not being allowed to use those medications in the hospital, or having limits on when and where those could be initiated. So I know, for example, when we started on our consult service, we were only allowed to prescribe or to administer up to 40 milligrams of methadone unless the patient was already enrolled in a opioid treatment provider in the outpatient setting. And so that was obviously very, very limiting, especially in the era of fentanyl, where people are requiring higher doses of methadone. And so that was something that came out very frequently, is these institutional barriers to providing appropriate patient care. Next slide. So these are just some quotes from participants that get at that. So that first one from the social worker talking about that pressure to discharge people, you have to get them out. That's really the primary priority. The priority is not really necessarily good patient care, but getting people out of the hospital as fast as possible. At least that's the way things were perceived by our participants. And then this second quote talking about, it's not about being tired. It's not, you can have a very busy clinical day. You can talk to a lot of people. You can do a lot of things and you feel tired, but it's really coming up against those systemic barriers that makes you feel really burnt out. All right, next slide. All right, so our next sub-theme within that systemic barriers theme was barriers at a broader local, regional, and national level. And this, I think, really will resonate with a lot of people. Again, especially when we were doing these interviews in the era of COVID, community-based resources are lacking and were especially lacking. So there were still a lot of limitations, a lot of virtual move to virtual therapy, limitations on how many beds inpatient facilities could take. Just the resources were not there. People needed care and couldn't get it. And so that came out a lot, is just we see people who are really, really sick and we can't get them the care that they need. And then the other thing that came out was federal policies limiting the use of methadone. And actually, this was enough of an issue that we published a second paper just looking at every time somebody mentioned the word methadone. I think I forgot to include that in these slides, but we did a secondary analysis because the idea that institutional or federal policies limit the use of this really evidence-based medication and that negatively affects patient care came out over and over again. Next slide. So again, this first quote is just getting at that lack of resources in the community and lack of access to services. And then the second quote gets at this limitation on methadone use. So having really sick people who would really benefit from methadone, but not being able to get access to this medication. All right, next slide. So on a more positive note, our next theme was all about resilience. So how engaging in meaningful work increased physician resilience. Next slide. So the first sub-theme was really people enjoyed their work. So people felt like doing addiction medicine, providing addiction care to patients is really satisfying. They really enjoyed caring for a stigmatized population. They felt like their work was appreciated. And they also felt like it was important to have a perspective where small victories are meaningful, kind of acknowledging that we are treating a very sick patient population, and really anything makes a difference. And so having that mindset and that attitude really helped kind of promote resiliency. Next slide. So this first quote is about, just being able to be present. I think we're all aware there's a lot of stigma in the medical community against people with substance use disorders. And so being able to just be there and providing non-judgmental, non-stigmatizing care, that was something that came out very frequently from our participants that felt very meaningful. So people saying, you're the first person in this whole hospital who has not judged me, felt very meaningful to that first participant. And then the second participant, one of our social workers, talked about, just feeling humbled and appreciative of being able to do this work, and just feeling like, making those small differences is something that's very, very meaningful. Next slide. So again, going back to sort of the demographics of our study population, a lot of our folks were working with learners, and this idea they could be an educator was also very, very powerful and contributed to the idea of resiliency and their perception of resiliency. And this also extended beyond just working with learners, but also working with, other clinicians, being able to sort of influence peers in a positive way and change attitudes toward people with substance use disorders was very, very powerful. And a lot of people also felt like, their identity as an addiction provider, they really enjoyed working with other addiction medicine providers, and they enjoyed working in a team setting with other people who are kind of like-minded and advocacy focused. And then the last one is almost the flip side of the first. So that idea of the systemic barriers contributing to burnout, when people were able to enact systemic change, they found that very satisfying. So people talked about that largely in the setting of doing local quality improvement projects. So for example, being able to get patients methadone or buprenorphine in the hospital, doing that kind of quality improvement project, or treating somebody's hepatitis C, changing policies so they can start people on treatment in the hospital. So that kind of thing people found was very satisfying. Next slide. So these quotes again kind of get at those ideas. This first one is about the idea that addiction medicine people are very advocate-minded people and really enjoying that. And then this second quote talking about, working with the early learners and then seeing those learners go off to do rotations on a surgery service, or, finish medical school and residency and go on to become providers in all different specialties themselves, and feeling like you're able to influence their perspective at kind of this early stage and allow them to have a more hopeful and positive view towards the treatment of substance use disorders. Next slide, please. And then this is just a whole bunch of quotes with the word advocate. So this came up very strongly, this idea that being an advocate is extremely satisfying and very, very meaningful. So thinking back to that model, the centerpiece was meaning and work. And that was something that people felt very strongly when they felt like they were able to advocate for their patients. Next slide. All right, and then this last theme was all about kind of team dynamics. So I know our first theme was about burnout. The second one was more about resiliency. This was kind of a mixed theme, that the idea that the team dynamics can sort of promote burnout or resilience. Next slide. So again, this one might be a little bit, well, I think in some ways this is very applicable across the board. In some ways, this is a little bit more limited to that inpatient setting. I think one thing that is applicable is people really liked working with an interdisciplinary team. So, and specifically some of our physicians that we interviewed who were working by themselves, they really felt like they would benefit from having another perspective and somebody else who could help, fill the different roles on the team. But people who worked on sort sort of a robust team with like peers, navigators, social workers. They felt like everybody was able to sort of provide something in their own role, and they were able to learn from their team members, and just really enjoyed that dynamic. And then also we asked a lot of questions about sort of how to deal with negative encounters, and people talked about being able to debrief challenging encounters with their teammates. Some even described sort of having a standing, almost like a morbidity and mortality conference, where they talked about challenging encounters with oftentimes other staff in the hospital, sometimes with patients, and just being able to talk through those with teammates was really, really beneficial. Next slide. And then the idea of being in a consultant role. So again, most of our folks had other jobs, and they really enjoyed being able to come in and just weigh in on this one specific issue. So very different from, being the primary provider on a hospital medicine service or being the primary provider as a family medicine physician. It was just a nice kind of change of pace, and it was nice to be able to focus their whole attention on that one issue. Having said that, when their expertise was ignored, that was very, very frustrating and contributed to feelings of burnout. So this came up sometimes, we'll go see a patient and we'll make recommendations. And then, oftentimes it was the surgery team that was brought up. The surgeons don't want to do what we say, and that feels bad. And that was kind of the perception of our providers, is then they felt they felt undervalued. So that was something that came up frequently. All right, next slide. So yeah, this first quote, just saying it's nice to be the consultant. You come, you talk about this problem. And then the second quote talking about that idea of, it's really frustrating when you make these recommendations and they're not taken. Right, next slide. So those were our three themes, our 6 sub-themes. The implications, again, I think really some of these are more specific to hospital-based care, but a lot of them I suspect resonate across the board. I think one of the big things that came out is these ideas of stigma and advocacy being closely related concepts. And then again, sort of this flip side of the coin. It can be really frustrating and difficult and challenging to work with a stigmatized patient population and coming up against these systemic barriers. But on the flip side, when you're able to enact change and you're able to provide non-judgmental care, that's very, very satisfying and meaningful. So, I think one of our takeaways was that when there are opportunities to engage in advocacy, that's really protective. So this could be institutional level, just as simple as educating peers or learners, local quality improvement projects, systems level, engaging with community and national organizations to promote policy level change. These are all things that have the potential to sort of protect our providers against burnout. Next slide. So just in conclusion, I would say what we found is that addiction medicine providers really feel a deep sense of purpose working with marginalized populations and are strongly motivated advocates. However, this work can be a source of burnout, especially when consult recommendations are ignored, people feel stigmatized, and education and advocacy work fails to move the needle. And that's it. I think there's one more slide that just has the results of our study. And then again, there's a second study by Dr. Calcaterra that focuses on methadone specifically that I forgot to include here. Thank you so much.
All right. Thank you, Dr. Breedenberg. I mean, I think that's a really comprehensive study that you did. And really, I know aside from a lot of medical practitioners on with us, we have many advocates. And so in the, prevention and treatment fields, and to see the role advocacy plays for all of us, and how empowering it is. Next, so thank you for that. Next, I'm going to turn the presentation over to Dr. Shivendu Sen. Dr. Sen is going to give us some tips to how to achieve that balance and self-care and mindfulness. So, Dr. Sen, I'll turn the presentation over to you.
Thank you very much, Angela. Thank you for the invitation. I have worked with the Partnership for Drug-Free New Jersey for many years. I will say close to a decade. And again, thank you for all the great work that you do. So I will, in contrast to Dr. Bredenberg's wonderful lecture and very objective and to the point, I would probably go a little general, more subjective, more holistic, and look into the various way we can address the burnout, and also the various ways we can circumvent the challenges and the stress that comes on, not just in addiction medicine, but in general while we provide patient care. Next slide, please. So I'll start with this favorite quote, where resilience or any steps that we take to address stress is only an inward journey because we are all born in the state of peace. So whenever we are thrown into the world of stress, resilience is only a journey back to the state that we were born with. Next slide, please. So, some objective points, when we talk about burnout, we usually talk about a tri-dimensional syndrome. There's obviously the emotional exhaustion of, feeling anxious and getting stressed out and having, even panic disorders, even though we are healthcare providers. And then this depersonalization that subconsciously, seeps in. We have all individual personal traits, if you're a father or a mother and a sister and a brother, and at the same time we are caregivers at any levels, whether I'm a nurse or a social worker or a physician or a physician's assistant. There is this depersonalization where we are kind of groomed to believe that this is our main personality because we're in the business of giving care and saving lives. But then there's always that positive thing about personal accomplishment, something that Dr. Biddenberg also alluded to, the satisfaction of taking care of someone. So that's the positive part. And if I may use emotional exhaustion and depersonalization being the negative part. It reminds me because I was lecturing at Harvard University, and then I was asked, somebody stood up and asked, "You've been talking about positive and negative, Dr. Sen. So, what exactly is being positive? What exactly is being negative?" And I gave the example that it's like a 20-minute phone call to your daughter or to your son. The first 18 minutes was a fantastic conversation. And the last 2 minutes, you had a difficult conversation, you had a fight. But the problem is, you spend the rest of the day thinking about those 2 minutes of fight and not the 18 minutes of wonderful conversation that you had. So that's negativity. So, but the positive side here is this gratifying sense of taking care of someone, what we call as a personal accomplishment. Next slide, please. So it's a subjective burden, very simply as I put it in brackets, it's a consequences of caregiving. It's obviously physical. There's so much amount of physical involvement whenever we take care of patients. As I said, not just addiction, but in general, across the board, there is anxiety, there is stress, there is panic disorders, there is depression, there is personality disorder. All of these things, subconsciously, they sip inside us. Psychological, emotional, the kind of overlap, and also social. That plays a huge role in the process of the patient care that we do. We have to realize that when we take care of a patient in whatever capacity, in an institution or in a nursing home or any facilities, when we come out from that facility, it does not mean that it stops right there. We carry the traces of our taking care of that patient. We carry the footprints of that. And that interferes subconsciously, again, consciously or subconsciously, into a family life, into a community life. And that causes all these sorts of social problems that we have. And of course, the financial problem. Sometimes, not all of us are very highly paid, and you're looking at doing multiple jobs, and then there's so much that you and I can do. We've got two hands, and we need to juggle so many social and financial demands that we have. Next slide, please. This is a busy slide. Each of my lines could be my separate lecture. How you understand stress. I read this very famous quote where a doctor said, "Stress is actually neutral." You know, we make it look very negative. Some of us we work very well under stress, and some of us we buckle under pressure. And this Lazarus and Folkman stress theory, there is one word that we look for. It's about the resources. If I know that I have the resources, if I know that I have the alternative means, then I can meet up with the demands of caregiving. But if we do not know the various resources, or if I have inadequate resources and I have nowhere else to go, and I'll get into the next slides, we'll talk about where are the areas to go. Um, then we have a problem. So it's a relationship between the demands of caregiving and the resources we have to address or to circumvent the sources of stress that comes out of caregiving. And then we have the stress process model. The stress process model is simply the journey. All of us who are in this process of taking care, we have three journeys. We start from home and we have a situation there. Then we have on the way as we go, we have moments of stress there because we are journeying to that place and to the place where we work. Stress process model talks about these three destinations that we always go through. And then the appraiser model, which is a very popular model that we talk about, which is the way you look at it, whether it is a threat or whether it is a challenge. So, challenge is when we look at it in a very positive way, how we can grow despite the challenges that I come across during caregiving. Or the other mindset is I feel threatened. My family life is threatened. My personal life is threatened by the burden of caregiving. And the last is the model of carer stress and burden. We talk about primary stressors and secondary stressors. Like I'm stressed out as a caregiver, but then the secondary stress is I'm giving it to the subsequent person, and that person is stressed out because of the stress that I give. So those are the four important things that we go for. Next slide. So again, we look into the various pathways of stress, the primary stresses, the secondary stresses, the appraisal, as I mentioned before, uh, how we look into it, and then the outcomes that we come across, and then the exacerbating factors and the mitigating factors, which we will talk about later. What are the factors that can make it easier for us to go for the caregiving? Next slide, please. So again, this is just a figure that we use when we have our annual feedbacks about how to take care of caregiving burden. You try to identify the primary stresses, then you identify the secondary stresses. A lot of mishandling of patients usually come from secondary stresses. And then we look into the background factors, what's caused it. Then we look into the appraisal factor, whether we can convert the mindset of threat into a mindset of a challenge with all the resources that we have, given by the institution, given by the community. And then we look into the outcomes. Next slide, please. So that's again a part of the Lazarus model that we talked about. The demands of the job depends upon the resources that you have to address the demands that comes. And if we do not have the adequate resources, that's what leads to the burnout. But if we know that the resources that we have, then that's a positive engagement. That's a positive outcome. Next. So let's go back to this holistic thing that I was trying to talk about. What exactly is a burnout? Now, the first two lines are the easy ones. When you feel exhausted, you feel overwhelmed, you're anxious, you easily become impatient. These are the ones that we flaunt, we caregivers, when we are pushed to the corner. But the subtle ones are the ones that we always discuss in our get togethers and meetings that we have at various levels of healthcare. Whether you are feeling lonely and you do not know why you are feeling lonely, you feel disconnected from the others, you have trouble sleeping, you have this feeling of hopelessness. And then you have the physical, the somatoform disorders. You have frequent headaches, you have the pain, you have other types of physical problems like abdominal cramps, and you don't have enough time to exercise, You start doing skipping the obvious things that we always do, like skipping showers or other personal cares, like even brushing your teeth. And then comes misusing alcohol and drugs, including prescription medications that you lean on. So those are the manifestations of a burnout that we get, the obvious one as well as the subtle ones. Next slide, please. The first few brave steps. This is a busy slide, but when we all get together, if you ask me to just replace all these lines with one word, I would just say ask. This becomes the greatest barrier. When we take care of patients and we feel burnt out, and again, it could be any one of us, a case manager or a social worker or a physician assistant or a pharmacist. The greatest barrier is ourselves, because we don't want to ask. Because we think that since we are caregivers, we are in that position where we have to be perfect, where we have to be right, where we cannot have any shortcomings, and that's what makes things worse. So the first thing that we always say is that ask. It is perfectly all right for us to ask that, can I be helped? Is there a human resource which can give us some instructions? Are there a group of behavioral therapists who are there whom I can approach and still keep my job and still be respected and still preserve my self dignity and still be considered to be perfectly capable of taking care of a patient? So these are the underlying factors subconsciously that plays within us, which says, you know what, I'm not going to ask anybody. What if it costs my job? What if people start looking at me and said, Dr. Sen is not the best person to take care because he himself is suffering? So that's the first thing that we say, that we need an environment in an institution, whether it's a hospital, whether it's a nursing home, whether it's any addiction center, that I, as a provider, if I feel pushed to the corner, whether I have the right resources, where A, I can be helped, and B, my capability will still be respected. So that's the first few brave steps that we need to take. Next slide, please. So those are the formal coping steps. When I say formal, because there are other informal ones that I will get into it. You must talk to your primary, whoever is your supervisor. It is perfectly okay not to be okay. We need to be comfortable with the uncomfortable. We need to walk in to my supervisor's office and say, these are the problems that I'm facing. I think these can be circumvented. I need some resources. I need some help. And then we speak out. We speak out. If it's an emotional exhaustion, if it is a mental instability, we speak out and we say, and we all have resources that every institution has. If it means going to a counselor, so be it. They work miracles. I have come across many instances where my colleagues, my peers have gone to for counsel, and they have come out like champions. There's a human resource department. There's a faith community out there. Spirituality plays a tremendous role in bringing us to where we started with. And that faith community can be in your community, can be in the institution. There are various ways to reach out if spirituality is something that you think, because these are very personal perspectives. But I have come across many instances where people have gone to their faith community, said, you know what, doctor, and I feel so much more better. In a way, you take care of patients much better once you get the resources which you think are apt for you. Next slide. These are things that you and I know, but I always mention it because it's very essential to be active. It is very essential to eat well. Now, this is so simple, but the thing is that these are things that we need to take it as an exercise. It's not just I don't feel like eating, hence I'm not going to eat. It is important. It's the other way around. If this is done, eating is done in a conscious way, that nourishment helps our brain and our mind to address the negativities that we come across. It's important to sleep. I itemized reduction of the stress because my following slides will talk about this reduction of the stress. You should make time to relax. And the last word that I had, uh, let me just go back to, yes, and take a break if you need it. It's so important to take a break. Yes, it is, you're taking care of your patient. Yes, it is a very honest and a great you know endeavor, but it is very essential for take a break. I tell my uh, juniors, I take my residents that as much as we love what we do, always remember that we take care of suffering, we take care of sick people, and that gets inside. It is important for us to take break and then rejuvenate and come back and take care of our patients. Next slide. So stepping outside the box, our respite care, it is very important for us to know. In one word, it means try to identify who's the caregiver of the caregiver. That is very important for us because for all of us, we need a caregivers while we are being caregivers. And my caregiver is very personal. It could be music, it could be motion, it could be meditation, it could be a friend. All of us have our own caregivers, and but we don't give ourselves the time to think that this person is my caregiver, or this community is my caregiver, or meditation is my caregiver, and to follow that, to religiously follow that, so that we can go back to, as caregivers, to our own caregiver and get cared for, so that we can come back and take care of our patients. A thank you diary. I tell wherever I'm called upon to speak that, if you think about the 24 hours time that we go through each day, if you close your eyes and you think that so many people have helped us, from the guy from the car that stops to allow me to cross the street, to in the grocery store, the guy who gives me an extra bag. If you think about it, you'll probably have 5 or 6 people every day where you should be to whom you should be grateful to. And how can we not feel better when we know that each and every day I have 5 to 10 people who's actually been my caregiver? Write yourself a love letter. When is the time? When was the time? Because we get so involved in taking care of patients, we are so involved in taking care of patients, we don't even have time to take care of ourselves. And very importantly, what we discuss is to be subjective and not to be objective all the time. There are certain things that's making things difficult for you. Don't be objective and say, I'm the caregiver, I'm getting burned out, and I should not be burned out. Well, you should be burned out because it is an exhausting job. So you got to put yourself in the right subjective background. Next slide, please. And so I'm coming into my last few slides. There's a Harvard breathing technique where uh, this technique is actually in the website from the Harvard Medical School. It's a very simple technique, and I'm not going to go through all of them. It just says that you just lie flat and you tighten your abdominal muscles, and then you actually breathe in and breathe out. And incredible number of researchers have proved the simple breathing. And there are certain numbers called 4-6-8, which means you breathe in a count of 4, you hold your breath in a count of 6, and you let it out in a count of 8. And it's not just Harvard Medical Schools. Oxford and many institutions in Germany have actually come out that Harvard breathing techniques should be used by us caregivers on a regular basis. How many times? As many times as you can, because this is not a medication. Medication will have its own tolerance effect, will have its own sweet side effects. These breathing techniques have been proved to calm our mind internally, and could be done, as I said, as many times as you can. Next. And I will get into my last 3-4 slides would be on meditation. I'm a big advocate of meditation. There are 2 types of major meditations that we caregivers uh, should be aware of, and we should practice. Mindfulness meditation. All those words that I've listed are part of meditation. You just sit there, and you don't have to sit like a Buddha under a banyan tree. You can take a just comfortable corner and just sit there away from some noise and just breathe in and breathe out. The Harvard breathing techniques that I say, that itself is mindfulness meditation. You just let your thoughts come in. Don't stop your thoughts, because thoughts will come. We are human beings and we are caregivers. But let those thoughts come and float across you, and do not be judgmental to the thoughts, whether they're good thoughts or bad thoughts or disturbing thoughts or stressful thoughts or thoughts about your patient or thoughts about the hospital pressurizing you, let them come, but give them the time to drift away, and they will drift away. And that is what mindfulness meditation is. Next slide, please. Yeah, my next two slides are basically just, I'm going to wrap it up because this particular slide is itself a lecture for me. Uh, just to bring about this gentleman on your left side called Ricardo Mathieu. He's a very well known scientist in France. And he was having these burnout things, and he went to His Holiness the Dalai Lama, and he started to meditate. And he had a friend, Richard Dawson, who is actually from Wisconsin Neuroscience Lab, and he approached Dalai Lama and said, my friend is undergoing all this meditation. Can I do some tests on his brain to find out whether meditation actually helps? This is almost like a cult. We say meditation helps, but does it help? And Holiness Dalai Lama said, absolutely, go ahead and do it. And so this beautiful experiment started where the person on the left, Dr. Ricard Matthews, started to meditate week after week, day after day, month after month. And Dr. Richard Davidson used to take him to his Wisconsin lab and do all the MRIs. And lo and behold, it was found that those exact areas of the brain that got hit with stress, namely the left hippocampus, the prefrontal cortex, the amygdala, those areas had tremendously heightened neuronal activity. As a matter of fact, very recently, BBC called Dr. Ricardo Mathieu, the gentleman on the left, as the happiest person on earth because his amygdala was found to be so much enlarged. This slide I included just to put the science behind the art of meditation. Next slide, please. And just to continue, I mean, Sir Roger Penrose, he won the Nobel Prize in quantum physics. He also focused on meditation. Dr. Hemmeroff, very famous and well-known physician from Arizona. He himself, the gentleman in the middle, Dr. Walter Freeman, and he's in a conversation with myself. So this is the whole group of scientists who have actually conclusively proved the effects of meditation on everyone, but specifically for us caregivers because we are in this very demanding job. Next slide, please. And then there's the other type of meditation, and I know I'm reaching the our time, so I'll probably be very quick at it. This is the other type of meditation for some of us who find mindfulness meditation to be difficult. To sit quietly, let all the non-judgmental thoughts go across. We find more benefits in using a word of your choice from your religion, which you think is you're very comfortable with, and to just repeat those words. That increases the concentration, that increases the focus. That, in essence, is known as the transcendental meditation. And many people, not just caregivers, my next slide will tell you. Next slide, please. Yeah, this is Beatles. So from John Lennon to Sir Paul McCartney. Sir Paul McCartney, even now, he uses transcendental meditation, which helps him to address all the complexities of the world that he faces. And of course, he has his own music. John Lennon was a big proponent of transcendental meditation. So, music, meditation, resources, we all have for us caregivers. We just have to ask, we just have to be active, look for the various resources that we have, and that's how we can help the burnout that comes to all of us while caregiving. Next slide would be my reference, and I would like to thank everyone.
Thank you so much, Dr. Sen. Really, such amazing information that you shared. And following Dr. Breedenberg, with her understanding of how many of us, and how many caregivers in general are feeling that stress and burnout, so important. So, Dr. Breedenberg, I think I'm going to go to you first, with a question that we had just on your the question just on the study that you did, and wondering if the participants' opinions in regard to systematic barriers fluctuate when the demographics are considered or of consideration.
Yeah, so how might differences in demographics contribute to that perception of the systemic burnout? Yeah, because most of our folks were physicians. I think that's very relevant. And I didn't give the rest of the demographics, but I think it was a heavily like white, sort of mostly folks in their mid, some early career people. And I would say that I think that definitely has an influence on how people perceived those issues of burnout and resiliency and the importance of systemic change. And I'll also say, with this qualitative work, I was thinking of this as Dr. Sen was talking. We have many, many, many hours of recorded interviews with folks, and it's difficult to try to narrow down and capture the themes across all of the participants. And so what came out is really what we felt were, the most important themes that people were expressing. But there was a lot that we weren't able to capture. We asked questions about how do you deal with burnout on a day-to-day basis. We didn't actually give any definitions of burnout or resilience in our study because we wanted to, and we didn't do any objective evaluation of whether people were experiencing burnout or resilience because we wanted just to hear what people felt. That was really our goal, is to get the perspectives of the people we were talking to. So I think that's sort of a long-winded answer, and that I definitely think it affects people's perceptions. And then that we acknowledge that was a big limitation of this study, is that we focused on a very specific population. And then also there was a lot that came out that just, we couldn't just capture in this one summary of our results.
No, understandable, understandable. Um, so Dr. Sen, I'll go to you. If you know a colleague or even a family member or a friend, particular a colleague, how would you recommend assisting them or approaching them without kind of overstepping any lines and keeping that professional relationship appropriate? Have you had any experience with that or any best practices you can recommend?
Yes, I mean, these are, situations that we routinely uh, go through in our hospital, in our institution, where we encourage everyone to feel comfortable to address any situations of challenge, and we open up, and so that we should understand the fact that as I said, that the greatest hurdle actually comes from our mindset, where we actually think that reaching out is actually equivalent to my inability to take care. So that's the biggest barrier that we actually go. So when people come and address to me, um, obviously it is a closed door meeting. Obviously, there is a lot of privacy, and to make someone feel very, very comfortable that this is not related to the performance, although I understand this is coming out of your performance. And there are various options that we give out. And if it is a physical involvement, then it is a physical help. If it is emotional, then it is an emotional help. If it is needing a break, if it needing someone to take care of your shift, because sometimes it all depends upon the type of work, is also related to geography. It's also related to the timing. If it's a night shift, if that's bothering the whole family life, and that is bothering the caregiver's performance, we give options that if you want to come out of a night shift, if this day shift is something going to happen. So these are very personal, very objective, mm, issues that we discuss, and it varies from person to person.
Person. And before I go to both of you for a final thought, Dr. Breedenberg, did you want to jump in on that? Whether does that come up in any way in any of your studies on working with colleagues who may be burned out and how to approach that?
Yeah, that's a great question. We didn't specifically ask questions about that. We asked, how do you support yourself to promote resilience and combat
No,
burnout?
absolutely.
But we didn't ask about supporting others. I mean, I think a lot probably a lot of people talked about talking to colleagues or friends or family members and getting support from others. And but I will say we didn't explore it in a structured.
No, absolutely. So it just I'll just while you're any thoughts or last tips, Dr. Brunenberg, that you would leave as a final thought to all of our attendees today? Again, understanding that we have many health practitioners on with us. We also have prevention and treatment professionals, law enforcement, EMTs, pharmacists, advocates. Uh, any last thought for them?
Yeah, I think that my big takeaway from our study was that there's a really fine line, again, these two sides of the coin, that the thing that make this work so meaningful is also the thing that makes it so hard. And so walking that line between, finding ways to promote resilience, it's very challenging. And everywhere that there's sort of an opportunity for improvement, that's an opportunity for stress and burnout as well, but also an opportunity for resilience. So I think it's a difficult question, but definitely I think that was my major takeaway is how, again, those two sides of the same coin.
Absolutely, absolutely. And Dr. Sen, we'll go to you for our final thought of the day.
Well, I would just echo what just Dr. Wimberg said. It's very meaningful, but it's very hard. It is hard. Let's face it. It's very challenging. But then there are resources available, and that we should know the various resources available, and we should actually try to reach out to those resources. There is no difficulty, in no barrier should be there in reaching out to those resources.
All right. Well, I want to thank you both for being with us today. I also want to thank all of our attendees for joining us. I hope that you learned something today that can help you in the work that you do and in your everyday life, and help you prioritize resiliency and self-care. And so I thank you for that. I hope that you will join us for our next webinar, the opioid crisis, where we stand as 2024 concludes. And for those of you who have been joining us throughout the year, we're going to be revisited by our January speakers, Dr. Lewis Nelson from University Hospital and Captain Jason Piotrowski from New Jersey State Police, who talked to us in January about what we were anticipating seeing in 2024. And so now we'll look at where we actually are. And so looking forward to that. And I hope that you can all join us. Once again, thank you to our expert speakers. Thank you so much for all of the wisdom that you shared with us today. And thank you again for all of our attendees. Information on how to get continuing education is available. You'll see it on your screen. You can visit the website, knockoutdata.drugfree.nj.org/NOV14. So thank you again, and have a wonderful day, everyone.
Thank you.